Thank you.
I'm very happy to invite Honorable Registrar of Dr.NTR UHS, Dr. Shankar garu. We welcome you, sir. And I take the privilege to invite NSS Chairman and Honorable Vice-Chancellor of Dr.NTR UHS, Dr. Shyam Prasad garu. We welcome you, sir. And I'm glad to invite today's chief guest, Professor K. Srikanth Reddy garu, President of Public Health Foundation of India. We welcome you, sir.
Thank
Now, let's begin the program with welcome address by Dr. Vivekanand Kattimani garu, Program Convener. Over to you, sir.
Thank you very much, Meghana. It's a nice welcome to all dignitaries. So before I give my welcome address, wishing you all happy Doctor's Day and very good afternoon to all. Once again, I, Dr. Vivekanand Kattimani, welcome you on behalf of Dr.NTR Health University, Andhra Pradesh, the celebrations of Dr. Day hosted by NSSL. Doctor's Day is celebrated in the remembrance of contribution of doctors to the well-being of nation, annually on 1st July. And is also birthday of legendary physician, Dr. B.C. Roy. The dedication and service to the society has been recognized by the Government of India. B.C. Roy Award was initiated and instituted in 1962 for the doctors for their exemplary service to the nation in the memory of Dr. B.C. Roy. It is presented by President of India in New Delhi every year on this day. It's also the highest honor achieved by the doctors in India. I hope all the budding doctors will take inspiration from the magnanimous personality to serve the nation for betterment of the mankind. With this welcome note, once again, I thank university authorities for their initiation to conduct Doctor's Day program, first of its kind in the university. Thank you very much. Over to Meghana.
Thank you, sir. Now, I welcome Honorable Vice-Chancellor of Dr.NTR UHS, Dr. Shyam Prasad garu, to address the gathering. Over to you, sir.
Thank you, Meghana. Om Sai Ram, Harihi Om, Namaste. Very good afternoon to all. Wishing you a happy Doctor's Day. Today is the day we're remembering the service of the doctors in the nation for healthy mankind. Dr. B.C. Roy birthday was celebrated as Doctor's Day nationally and as 1st July every year. And I thank and congratulate all the doctors involved in working, especially the NSS volunteers, COVID warriors, and dedicated service by the doctors, paramedical staff who are controlling the entire pandemic in India, especially in Andhra Pradesh. We will just remember the Bidhan Chandra Roy, B.C. Roy, was born in 1882 in West Bengal, and he is unique in having 2 degrees. One is FRCS, MRCP. Both as medicine and surgery is mastered at England. Later, his service has gone into various parts. He has done, to start with, establishment of TB Hospital, Chittaranjan Seva Sadan, Kamala Nehru Memorial Hospital, for Women and Children Hospital, so much so on. And he was a Vice-Chancellor for the University of Calcutta at that time. He was Chief Minister for 12 years and way back to 1948 to 1962 in West Bengal. And he has done enough work to standardize. The most important thing is B.C. Roy Award to the doctors in India. We secure that one with a lot of good enthusiasm for all doctors. They are doing enormous work as a doctor, as a human being, showing all empathy and treating all doctors. In this regard, I will once again congratulate the budding doctors, wish all the best for future endeavors. Thank you, Kattimani.
Thank you, sir. Over to Meghana.
Thank you, sir. Now it's time to introduce the chief guest. I request Dr. Vivekanand Kattimani garu to introduce today's chief guest to the August gathering. Over to you, sir.
Thank you, Meghana. So it's my pleasure. I think Professor Reddy garu, well-known personality in the field of medicine, who doesn't need any introduction. But it is a customary that I take a privilege to introduce today's chief guest speaker on the occasion of Doctor's Day to this August gathering. Professor Reddy garu obtained his medical degree from Osmania Medical College, Hyderabad, and MD Medicine, DM Cardiology degrees from All India Institute of Medical Sciences, Delhi. And sir further did his Master of Science in Epidemiology from McMaster University, Canada. Sir is the President of Public Health Foundation of India and formerly worked as a head of the Department of Cardiology, All India Institute of Medical Sciences. Under his leadership, Public Health Foundation of India has established 5 Indian Institute of Public Health in the different regions of India to advance multidisciplinary public health education, research, health technologies, and implementation to support for strengthening the health systems. Sir was appointed as the first Bernard Lawn Visiting Professor of Cardiovascular Health at the Harvard School of Public Health in 2019 to 13, and presently served as an adjunct professor of epidemiology at Harvard University from 2014 to 2023, and an adjunct professor of Rollins School of Public Health, Emory University, honorary professor of medicine at the University of also advisory positions in several national, international bodies, and recently published a book on Make Health in India, reaching 1 billion plus people. Sir is also is the first Indian to be elected for the National Academy of Medicine, United States of America, and was awarded several prestigious international and national doctorates and fellowships. Sir was the president of World Heart Federation in the year 2013 to 15 and awarded Padma Bhushan by Government of India. And Sir also serves as an advisor to governments of Odisha, Punjab, Haryana, Andhra Pradesh on public health and many more to Sir's credit. Sir involved in several major international national research studies, including InterSalt Global Study of Blood Pressure and Electrolytes, InterHeart Global Study on Risk Factors on Myocardial Infarction, and National Collaborative Studies on Epidemiology of Coronary Disease and Community Control of Rheumatic Heart Disease. Sir widely regarded as a leader of preventive cardiology at national and international levels. Professor Reddy garu has been a researcher, teacher, policy enabler, and advocate and activist who has worked to promote cardiovascular health, tobacco control, appropriate nutrition across the life course, chronic disease prevention, and healthy living across the lifespan. Sir is an editor, reviewer, and author for more than 500 scientific publications in international and Indian peer-reviewed journals. Also served on WHO expert panel and World Heart Foundation. Sir received many more awards and honors. They include WHO Director General's Award for Outstanding Global Leadership in Tobacco Control, that is in 2003 World Health Assembly, and Padma Bhushan in 2005 by Presidential Honor in India, Queen Elizabeth Medal by Royal Society of Health Promotion UK in 2005, then Luther Terry Medal for Leadership in Tobacco Control by American Cancer Society in 2009, membership of the US National Academy Institute of Medicine in 2005, Fellowship of London School of Hygiene and Tropical Medicine in 2009, and Fellowship of Faculty of Public Health in United Kingdom 2009, and honorary causa by universities, to name a few universities, Scotland and Dr.NTR Health University in 2011, and University of Switzerland and University of Glasgow in 2013, Doctor of Literature honoris causa conferred by Jodhpur National University in India, and Doctor of Science in University of London, UK in 2014. Sir delivered more than 50 invited orations and lecture, received many literary awards, and most prestigious literary awards such as Global Peace Essay Contest organized by Economist Allied for Arms Reduction, ICAR, and judged by 9 Nobel laureates, and the Times of India essay, many more career achievements to say. With this brief, actually Sir is having many more achievements. So with this very brief, I invite our chief guest to address the gathering. Over to you, sir. Srinath Reddy garu.
Thank you very much for that introduction. It's a pleasure
Dais
to
is
be
yours, sir.
reconnected to the NTR University of Health Science. Pardon? Pardon?
Yes, sir, you are audible, sir. Please go ahead, sir. Sir, you are audible.
Can you hear?
Please go ahead.
Can you hear me? Yeah, fine, thank you.
Yes, sir.
I said it's a pleasure.
Yes, sir, we can hear you, sir.
Thank you. Okay. It's a pleasure to be reconnected to the NTR University of Health Sciences and to be particularly connected to this event, which has been arranged by the NSS young and highly dynamically motivated volunteers. It is a great pleasure again to join you on a momentous day, which is the Doctor's Day. And since the people who are actually attending this function are either doctors in training as undergraduates or having already graduated and now undergoing postgraduate training, and some of them, of course, full-fledged postgraduate qualified doctors as well, and also members of the distinguished faculty, it is important for us to understand the significance of this particular day, which has already been elaborated by the Honorable Vice-Chancellor. However, when we really look at how a doctor is made through the educational stream and then positioned in society to perform several functions, I think one of the purposes of medical education as defined by Charles Mayo, who co-founded the Mayo Clinic with his brother, William Mayo, is that the purpose of medical education is to cure the sick and to advance the science. Now, Charles Mayo at that time did not position public health in it. He looked at the individual patient and wanted the role of the doctor to be for alleviating that suffering as much as possible, providing a cure wherever possible, but at least relieve the suffering to the maximum extent. But also to advance the science, because medicine is a science-based discipline and it derives its strength from ever-advancing knowledge, which is gathered from science. And when I say science, it's not purely biological sciences. There are multiple sciences that flow into medicine, right from physics, chemistry, and of course, now computational sciences, social sciences, and you have quantitative sciences like epidemiology, biostatistics, demography. You have management sciences. All of these actually come together to create a body of knowledge which advances the knowledge of medicine, enables doctors to acquire additional skills, and refine the manner in which they apply them for the benefit of the patients. And also for prevention, because as I said, one of the missing elements in Charles Mayo's definition was public health, because it is also important that the medical profession devote itself not only as people treating disease, but also promoting health and preventing disease. And that is the continuum, right from health promotion and disease prevention to early detection and care to palliation and rehabilitation as needed. That whole continuum of healthcare services has to be provided by the health system. Now, doctors may be positioned in different parts of the health system, but they have to recognize the role of the health system as a whole if they have to perform their own individual functions well, whether they are positioned in a public health capacity or whether they are positioned in a clinical caregiver capacity, or whether they are providing, in a sense, rehabilitation services at some point in time. It does not matter because they're all part of a functioning health system. And therefore, it is important for us to recognize that our medical education has to constantly update its knowledge, upgrade the skills, and strengthen the value systems that underlie it in order to enable every new medical graduate to become as complete a physician as possible so that he or she can deliver on all of these functions in society to the best of their ability. But it's also true that you will have to be a constant learner. You have to, because it is incumbent upon you to keep abreast of whatever science is offering to you in terms of advancements in which it is correcting past assumptions, coming up with new facts, also providing you with new technologies for use, it is also very important for you to be a constant learner. So that is one element that we must emphasize in medical education, that learning and the quest for new knowledge and new skills does not stop the moment a medical student leaves the portals of the medical college. But one of the very important elements, and particularly it's very relevant for the NSS, because they are seeing themselves essentially as people who are assisting society become a better place by providing a number of social services. There, I believe it is important for us to recognize that we have to think of the health system's role as a whole and see whether it is performing well or not and why it is not performing well. So let me, even on this rather happy occasion of the Doctor's Day, present you with a few discomforting facts about how India's health system is performing, because collectively we have to recognize where the faults are and how best we need to improve upon them. And that also explains why I moved from cardiology to public health. Because I was head of the Department of Cardiology, I still had 10 years of service left. I could have become the director of the All India Institute of Medical Sciences, or perhaps accepted other positions that were offered to me at a very senior level in the health administration of the country. But I felt that India was underperforming in health because we were having serious weaknesses in our health system. Public health was grossly neglected. The way in which our health systems were being shaped and governed was also defective. And therefore, even the limited resources that were available for health were not being spent properly in order to get the best health outcomes. And that is very clear in a number of ways in which we measure the health statistics. If you look, for example, at infant mortality, while India has improved a lot in the last decade, if you look at where India stood about in 2019, India's infant mortality was 30 deaths of infants out of 1,000 live births, whereas Sri Lanka had 6, Bangladesh had 25, China had 7. In terms of life expectancy, India's life expectancy was 69.2 years. Sri Lanka's was 77. Bangladesh was 72. Even Nepal has a higher life expectancy than ours. China, 76.5. And one of the reasons for this is that we have been grossly underspending on health as a country. If you look at the proportion of government health expenditure as a proportion of the total health expenditure. Of course, total health expenditure has been mostly around 4% or so, occasionally rising more than that, about 3.8 to 4%. But even that is low. But what is more bothersome is the fact that government health expenditure, which is very important for maintaining a large number of public services for health, India had only 30% of the total health expenditure coming from the government. Sri Lanka had 56%, China had 58.8%, Brazil had 46%, Japan had 83.6%, Germany 77%, Thailand 77.8%, UK with the National Health Service at 83%, and the United States of America, which is normally considered to be a poster child of privatized healthcare, and it quite often is highly dependent on private healthcare, despite the Obamacare or accountable healthcare program they have now, has 48.3% of the total health expenditure coming from the government through Medicare, Medicaid, and other programs. So compared to many other countries, we have a very low level of government investment in health. And that results in a huge amount of out-of-pocket expenditure. For many years, our out-of-pocket expenditure was between 70 and 78%. Recently, it had come down to about 62%. Current estimates, which will be available next month, probably may show that there is a slight decrease, but it will still be above 50%. Whereas Sri Lanka is 42%, China is 32%, Brazil is 25%, Japan is 14%, Germany is 13%, Thailand is 11.9%, USA is 11%, and UK is 9.7%. And the World Health Organization and the World Bank both say that your out-of-pocket expenditure, that means what a person spends out of pocket on that, which is not covered either by a government program or government furnished health services or by an insurance program, should not exceed 15 to 20%. And we are around 60%. So that again explains why we have such a huge problem. And even when we look at our health workforce, we often look at only urban areas and say, okay, there are a lot of doctors, a lot of nurses, but even there we are very short of doctors and nurses. But when we take the entire country and recognize the fact that 66% of our population lives in rural areas, and even in urban areas, there are small towns without adequate number of doctors and nurses, and even allied health professionals. And there is a huge maldistribution between urban and rural areas, maldistribution between states. But let me not go into too many numbers, just to say that the WHO in 2016 said that in order to achieve the Sustainable Development Goals and to achieve universal health coverage, you require 44.5 out of, for every 10,000 population, 44.5 doctors, nurses, and midwives put together. We are just around 22, half that number. So, and those who are there, as I said, are maldistributed. While 2/3 of the population lives in villages, 2/3 of our doctors live in urban areas and serve in urban areas. And even everybody who is registered as a doctor, who has been given a degree, is not actually working as a doctor. What we have recognized is that those who claim to be doctors in the various national surveys, about 22% of them are not qualified, actually properly qualified as doctors, and 27% of them are actually not working as doctors. They've either retired or they're doing something else. So we have a considerable shortage of people, and that is where our health system has been extraordinarily weak, and that is because we have not spent enough on health, and even our utilization has been very poorly prioritized, because we have neglected primary health care, both in rural areas and urban areas. We have allowed a somewhat unregulated private sector to flourish in the urban areas, but we have not corrected the disparities between rural and urban care, and we have not provided sufficient facilities for district hospitals to develop. We have not even provided adequate urban primary health care, as we found in the COVID pandemic, and we have neglected the launch of our and development of our National Urban Health Mission. And the Rural Health Mission, while it exists, has been having problems of understaffing and inadequate facilities. But we do need to recognize these problems. I'm not out to depress you on the Doctor's Day, but India's national bird is the peacock and not the ostrich. We cannot bury our heads in the sand. We have to recognize that these are unpleasant facts. If we have to correct them, and correct them we must. And therefore, when you are growing up as young medical students or young postgraduates, you must recognize that your own performance will be limited if the health system has its weaknesses. Your own knowledge skills cannot be exhibited best if there are shortages of equipment, if there are supply chain interruptions, if hospitals don't have oxygen, if you are not unable, if you are unable to get drugs on time. So you need to build up a very strong health system. And therefore, collectively, doctors must also demand that. Otherwise, you will be functioning with only half your efficiency and will not be able to live up to your potential and use all the knowledge and skills that you have acquired in your medical education. That is the reason I went into public health, because I felt that we needed to correct our health system. We needed to build more skills in our health system in order to actually ensure that there's a greater attention to some of the missing elements of the health system, and so that we actually both advocate for more funds for the health and also try and utilize those funds much better through better efficiencies of allocation and utilization. By emphasizing primary health care, emphasizing district hospitals, emphasizing medical college hospitals, building in better connected care, so that in the primary health care you have comprehensive care, you have chronic as well as acute care, you have continuity of care, and you have connected care, where people who require to go to advanced care in secondary or tertiary care are promptly recognized and referred, and when they come back, they are provided continuity of care in primary care. Unless we have those systems in place, you will have a very disconnected, disoriented type of care, where you will have suboptimal results, even if the doctors have a lot of skills. So that is where we must actually set the systems in order. And I believe it is necessary as a medical profession to collectively ask for a better system so that our skills can be better utilized. Otherwise, it can be extremely frustrating. What is the fault of the doctor if the doctor in a hazmat suit has been treating so many patients despite personal risk, despite great fatigue, and despite long working hours? If the oxygen runs out in the hospital, is it the fault of the doctor? But the doctor is the one who will get beaten up, unfortunately, by the agitated patients and the family, because the system has failed the doctor. Therefore, it's important for us not to think ourselves as merely care providers, as individual doctors. We have to think of ourselves as part of the system. And it also brings me to another point. Nobody is an individual care provider. We all function as teams, and it's important. Wherever we function, whether in primary care or secondary care or tertiary care, we all function as teams, whether it is nurses, technicians, or whether it is the ashas and the Anganwadi workers and the auxiliary nurse midwives. It is healthcare is ultimately team building and a team function. Just like in cricket or now in football, you find out that if there are weak players, then the team loses. Therefore, you have to build that team spirit and function as a good, efficient team. And therefore, that is also an important element that you must learn in medical education. And for that, one of the things that you must recognize is to shed false hierarchies. Don't think that doctors are super gods and nurses are inferior or technicians are inferior. Ultimately, when you look at a team, the team will be only as strong as the weakest link. One mistake made by one of your colleague doctors, one of your nurses, one of your technicians will cost you in terms of actual result of treatment and in terms of your own reputation. So build the teams well, build the team spirit well, build the team efficiency well, and that is where you have to really support each other also. And that comes in very handy, because when you are particularly under great deal of emotional stress, like for example in the COVID pandemic, you are facing a lot of odds, you're seeing a number of patients extremely sick and several dying, then you need that emotional stability. And that emotional stability will not only come from your internal resources, but also from the support that other members of the team give you. So you have to learn to support each other also emotionally. So both in terms of skills, complementing each other's skills, as well as in terms of emotional support to each other and learning from each other, I think team building is one of the important things that you must learn during the course of your training as medical students, interns, and as postgraduate students. Now, I would like to also say that from the point of view of learning, recognize that medicine, as I said, is a very science-based discipline, but it has many sciences to contribute. If you look at basic sciences, now if you look at even COVID, for example, look at the kind of developments that have happened with mRNA vaccines or other vaccines. So you recognize that basic sciences also have required many things. It's not just microbiology or virology, it is computational chemistry, it is bioinformatics, it is so many elements of basically bioengineering and physics, that computational physics that come in. So all of these are extremely important, even in the advancement of basic sciences. When it comes to clinical medicine, we must also recognize that there are several elements that you must learn. Now, why is it that people are unable to understand why a person who is having very clear-cut symptoms is having an RT-PCR negative, and why a person may sometimes have a false positive RT-PCR test even after full clinical recovery because some nucleic acid fragments are still there but without anything else, or there could be false positives for other reasons. You must understand that no test is perfect, that there are false positives and false negatives. And you must also understand that how to interpret a diagnostic test, because that depends also on what is called the pre-test probability, not just on the test result. So the post-test probability depends upon both the pre-test probability and on the test result. Let me just simplify that with an example. If a 60-year-old man who is a smoker, hypertensive, diabetic, has chest pain on climbing 2 flights of stairs and there's a central chest pain, then I know that if there is a 2 millimeter ST segment depression in the ECG, it is almost 90 to 95% likely to indicate blockages in the coronary arteries. On the other hand, if a 25-year-old woman who is anemic, has atypical chest pain, and has a 2 millimeter ST segment depression in a stress test, stress ECG, I know that it's likely to be a false negative, and the probability of her having coronary artery disease is not likely to be more than 20%, because the pre-test probability would have been less than 3%. So every test has to be interpreted in that context. And that is how you will understand the whole idea of what are called Bayesian analytics and the whole idea of probabilities. So there you will have to understand both statistics, epidemiology, and decision analysis. Now, you may say, this is not really needed for me. No. In future, you're going to be challenged quite a lot on your decisions. You're going to have data scientists trying to tell you what is right and what is wrong based on data analytics. And you will have people who will be going and doing a Google search and coming back to you and asking challenging questions. So you will have to definitely understand clinical research methodology. You may not become a researcher yourself, but you must understand whether a drug is really working or not. Nowadays, you see so many preprints coming into medical publication even before they have been peer-reviewed in a medical journal. So are you going to believe that hydroxychloroquine is effective or ineffective? Are you going to believe that remdesivir works in all patients, or whether it only works in a certain subset of patients? For this, you must understand research methodology. Otherwise, you'll be misguided into prescribing all kinds of things to all kinds of patients in all kinds of home and hospital settings, which is not only unscientific but dangerous, and you may be liable for legal action as well. So in order to care for your patients to the best of your ability, that ability must include skills of interpreting the findings of research. As I said, you may not become a researcher yourself, but you have to learn the research methodology in order to apply the products of research appropriately to your own practice. And particularly that depends on the context. Context also of what may have been done as a trial in some other country with some other population may not necessarily apply to your population. So you have to look at two elements, what is called internal validity. Was the trial itself properly conducted? Were there faults which are statistical? Were there any biased elements in that trial which are flawed and which created a wrong impression of the result? That's called internal validity. The second is external validity. How applicable are the results to your own population and your own patients? So those are important elements. So unless you start learning a bit of research methodology, even when you're medical students, and particularly when you're postgraduate students, you will be relatively an incomplete doctor. You may have learned certain skills which are clinical, but your interpretation of new evidence, how to apply, which drug to use when, which test to use when, how many tests to be used simultaneously, how many tests to be used sequentially, is it cost effective? Is doing the additional test going to give you incremental benefit of decision making, or is it a waste of money? Is it going to be biologically hazardous to do an unnecessary test when you already have a reasonable diagnosis with a high probability? Those are the kind of skills that you must learn. And these are important as you advance now into a 21st century world, where you're going to see a lot more of data sciences coming in, a lot more of artificial intelligence coming in, and many of these things will happen. Artificial intelligence will give you algorithms, but you cannot be dictated by algorithms developed elsewhere, because the basic data that went into those algorithms may be on a different population with different characteristics. You may have to develop your own algorithms here, or at least see how applicable those algorithms are to your population. So this is a very exciting time, but also a challenging time when you have to learn a lot of skills. But in addition to that, you also recognize that clinical medicine brings in, just like basic sciences, a lot of multidisciplinarity. You have to learn about ethics. What is ethics? What, not only in research, but also in clinical care. You have to learn about economics, because you don't want to prescribe 10 different medicines unnecessarily. What is cost effective? Those are elements that you may want to find out. So when you're evaluating healthcare technologies also, you want to evaluate from the point of view of both effectiveness and cost effectiveness. So these are all things that you must learn. You may not become a health economist, but you must at least understand what is cost effectiveness or not. And particularly in terms of statistics and clinical research, you must learn what is the difference between a relative risk and an absolute risk and the population attributable risk. They appear to be statistical terms, but they're so important, because otherwise what happens is you may say a relative risk reduction of this much, but in terms of actual total numbers of people benefiting, it may be very little. That may be just because relative risk is at the level of the individual, but not necessarily at the level of the overall group. And necessarily the number needed to treat becomes a very important element there as well. So these are not frightening concepts. These are simple concepts in statistics and epidemiology that you must learn if you want to become good doctors. But also you must learn when to use, as I said, tests simultaneously or sequentially, even in terms of avoiding tests which may be unnecessarily costly or have a biological cost as well. Then public health also is a very multidisciplinary science. It brings in biological sciences, social sciences, quantitative sciences like epidemiology, biostatistics, and demography. It brings in management sciences. It brings in health technology assessment. So there are a number of areas, whether you are actually going to be a clinical doctor treating a patient, you're going to be a basic science microbiologist pursuing viruses, or whether you're going to be a public health person trying to look at how infectious diseases can be tracked and controlled in the community, you must retain that breadth of orientation to multiple disciplines. Even if you have expertise in one area, you must have the awareness of how other disciplines are developing, so that you may be able to get some of the learnings from there. But that is not merely skill building or knowledge building. Knowledge building is absolutely important. As I said, you must update your knowledge, you must upgrade your skills on a regular basis. Be a regular learner, constant learner. But values are very important. The Vice-Chancellor referred to Dr. B.C. Roy. Dr. B.C. Roy emphasized the values of the medical profession very much. And those values are very important. It is care, concern, compassion, courtesy, good communication. Now look at this. Now you have to learn telemedicine. Previously, telemedicine was never taught in medical colleges. Now you have to practice telemedicine in COVID times. And that's going to stay even after COVID, because people have now got used to telemedicine, because it's both convenient as well as economical. So a lot of primary and secondary care can be done through teleconsultations. And teleconsultations in primary care can be provided to the patient, to the family, or to the primary care provider, who could be a nurse, it could be a primary care doctor, talking to a specialist in a hospital. But for that telemedicine, how to conduct the telemedicine, how to use it well, it requires skill building. And that is not part of our medical education. But if telemedicine is going to be part of our medical practice in future, then how are our medical students being trained, both undergraduate and postgraduates, for how to utilize telemedicine, both as recipients of telemedicine advice from a more advanced specialist, or as an advanced specialist to give that telemedicine advice to others, to listen with patience, to absorb all the facts that are and the various documents that are being presented in terms of the previous medical records, and how to actually give the best possible advice based on that. Those are some of the skills that you have to learn, which have never been taught in medical colleges before, but they're going to be part of medicine in the future. So there are a number of things that you will be seeing in the how medicine has to evolve. But one of the elements is also how best we actually define our soft skills, as I said, of care, concern, courtesy, and compassion, and better communication. Now, in a telemedicine, you may be able to give the advice in a purely scientific manner, in the best possible manner, but you may be impatient, you may be rude, you may be talking down to the patient, or a specialist may be talking down to the primary care doctor. That defeats the purpose of a good telemedicine consultation. So I believe that even in training, now we must introduce some of these soft skills and see how well the telemedicine conversation is being conducted. Now, in 1963, innovation was introduced in medical education, in which they had what are called simulated patients, where lay persons were trained to report certain symptoms, and actually even on physical examination to wince when a particular place where the right iliac fossa was being pressed or something like that. And they would actually mimic a patient, and the skills were being tested. And even examinations later on in several universities included the examination of simulated patients. Now, simulation patients are not really required in India because we have such a huge patient load, and we're not short of real patients. But how are we training them for telemedicine now? So are they able to absorb some of the information and give a correct diagnosis? Are they talking with sufficient patience and courtesy? We may have to come back to simulated patients even for training for telemedicine. We do not know. But whether we are using actual scenarios of telemedicine consultation or simulated patients, we must actually build up some of these new skills, which are not only technical skills, but also behavioral skills. And they're going to be very important. Same thing in an intensive care unit. Here is a doctor in a hazmat suit. The patient is very sick. The family is not allowed, not even allowed to peep in through the window in a COVID situation. How do you comfort the patient? What are the words you use? What is the tone of your voice? What are the non-verbal gestures that you use to give that amount of solace and comfort to the patient? How do you communicate with the family outside, which is so anxious? These are soft skills. Again, you must learn. That level of empathy must be built in. So even as we are moving into high technology, it doesn't mean that we distance ourselves from our role as empathetic, compassionate caregivers. That is also part and parcel of the medical profession. That is part of our DNA, to be compassionate and caring caregivers, because otherwise you are going to be easily replaced by robots. And robots are not going to be able to hold the pulse. So the whole issue here is, even Siri is not going, or Alexa is not going to whisper to the patient to give all the comfort the patient needs. So you do need to make sure that you learn all these soft skills. And as somebody put it beautifully, even if we are going to be practicing digital health in the future, it is both digital health in a technology way, but that doesn't rule out this digital health where you touch the patient with your digits. So that is an important element. So if you are going to be a trained doctor, therefore what I'm saying is you identify with the patient and the family and decide how best you can provide the best possible services in the most comforting manner. And that depends upon your scientific knowledge and skills, but also on a lot of your social skills. At the same time, you must recognize that you're part and parcel of the health system, and your ability to function with great efficiency is going to be either enhanced or undermined by the nature of the health system. Even the best doctor cannot work well if the system is extremely weak. Therefore, you have to try collectively as the medical profession to demand for betterment of the health system with allocation of more resources, with better utilization of resources, better monitoring of the health system functioning, and ensure that you are able to work in a supportive environment so to deliver to the best of your ability. So that is why when I ask for universal health coverage as a system, and we keep advocating that, it is not because it is something abstract. It is because it's going to determine how many doctors are going to be there, how many nurses are going to be there, how many technicians are going to be there, how are they going to be supported with equipment of drugs, and how are the systems going to be supporting their functioning, and how affordable is the treatment going to be, how available is the treatment going to be, what are the quality of services. When we define quality of health system or health services, we're talking about, is it beneficial? Is it safe? Is it cost optimizing? Is it providing satisfaction to the patient, to the family, and to the caregivers? Because if the doctors and nurses are extremely unhappy with the quality of the equipment, with the quality of the drugs, or if they feel that they're under attack by the patients, then there's no point. That's not a good quality, high quality health system. So how do we create those high quality health systems? It is our collective responsibility as a medical profession. So do enhance your knowledge and skills in every way, including your soft skills, while strengthening your values at the individual level. But collectively build teams for teamwork, and then recognize yourself as a part of a profession which must collectively ask for a better health system, which is going to be better resourced and better functioning. And therefore, think of the Doctor's Day not as a day when you celebrate the accomplishments of individual doctors. They are very important. Doctors are indeed heroes. But think of it where the medical profession is going to unite, build teams, including other healthcare professionals, and collectively work for a better health system. And then only we'll be able to get the best benefits of the medical education that a university like the NTR University of Health Sciences is providing us. And therefore, I wish you the very best on the occasion of the Doctor's Day. I was not actually planning to give a long lecture, but I was allotted 45 minutes. So I decided to make the best use of it by trying to speak of several things which I believe are important for medical education. I hope some of the messages have got through. And I really thank again the hosts, not only the Vice-Chancellor and the distinguished faculty, but particularly the young medical students and the NSS volunteers, because your spirit of service is what is fundamental to the soul of medicine. And I believe by being part of NSS and bringing that spirit of service into the medical college environment, you are actually reflecting the nobility of the profession. Thank you very much for that.
Next, Meghana.
Registrar of Dr.NTR UHS, Dr. Shankar, to address the gathering with closing remarks. Over to you, sir.
Good afternoon, everybody. So, good afternoon, Honorable Vice-Chancellor, Dr. Shyam Prasad garu. Good afternoon, today's great resource person and speaker, guest speaker, Dr. Srikanth Reddy garu. Good afternoon, sir, and good afternoon to all faculty members, students, and NSS volunteers. So we are very happy. So before that, I wish you all the doctors happy Doctors Day. We are celebrating this day by memorizing the BC Roy birth anniversary and death anniversary same day. We are celebrating this July 1st. And Srinath Reddy Garu very nicely and in-depth explained all the issues relevant to the today's public health scenario, explained in a nice way and focused on many issues. I think students able to understand or not. I have a little bit doubt also, because sir, these people, the students, medical and paramedical students, even if what you are telling also, nowadays they are unable to understand also. That is also another event we should be able to remember. So once again, I would like to repeat, actually not repeat. So Srinath Reddy Garu mainly focused on the public health and so many indices explained. So life expectancy and explained, and also about the IMR, infant mortality rate, and also that the personal investment, how have to offer as per WHO guidelines, how much is ideally is 15 to 20%, but our India is contributing personal investment is 50 to 60%. And importance of the urban healthcare and primary healthcare immensely. You have recognized the loopholes are in the system, and also sir highlighted over the personal skills, personal efficiency have no role at present. So that means no role means it is not complete. So it is a partial only. So always the medical system. So based on the teamwork only. Teamwork is a mandatory. So Srinath Reddy Garu stressed over the teamwork. So it's a combination of the medical and paramedical staff and social workers only we can make success in the field of the public health. So similarly, sir told about the soft skills and empathy very nicely. So technology will not give the artificial intelligence will not give the clue for all the questions. So you should have the empathy and the soft skills, how you have to develop. Explain in a nice way, sir. They are very thankful to you, which is nowadays lacking with the medical generation. So overall, we will take your advices to follow, sir. So on behalf of NTR University, on behalf of NSS team, we are regularly conducting programs in related to the public health, and we are calling a particular event, particular specialist as a resource person. So it is out of the one program, sir. And today, that is undoubtedly the doctors and healthcare workers serving and sacrificing their lives since 1.5 years in this COVID-19 pandemic. And this COVID-19 pandemic clearly exhibited the loopholes in the public systems in the world, not only in India, but all over the world. It exhibited what are the loopholes in the public health system, particularly in the India, and everybody observed. And almost all mortality and morbidity in COVID pandemic is due to the risk factors only, in my opinion. So what are the risk factors? You are all well aware. The risk factors mainly the lifestyle modification disease, that is lifestyle disorders. Lifestyle disorders. Due to the whoever having the lifestyle disorders, they are more suffered, more mortality were observed. So this is the fundamental issue. So India, unfortunately, all the lifestyle diseases like diabetes, hypertension, psychiatric diseases, and obesity. Of course, obesity is little problem when compared to the Western countries. But diabetes, hypertension, cardiac problems especially, and renal problems. So in all these issues, we are the leaders in the world. We are the top rankers in the world. So because due to the lifestyle disorders, we are unable to control the lifestyle disorders in a proper way. That's why in COVID pandemic also we are getting more mortality and morbidity. So we have to concentrate on the lifestyle disorders actually. So this is all as Srikanth Reddy garu told, it will take so long time to explain the public health system in India. So it will not sufficient. So I have to conclude in 2 to 3 minutes. It's not sufficient. So we can meet again in another issue, sir. We'll call you again back whenever you're free. We'll take again a meeting. But in my opinion, this is the public health. In nutshell, we can say this is two. We can divide into two parts. That is the before 1980s and after 1980. So this is the 1980s. So that is a very crucial time. The crucial time, all the reforms, the economic reforms entered into the India. So until that, it is having 80 to 90% of the medical system under government setup only in India. 80 to 90%. Only government or Christian minority people, they are running all the medical and health system. But after the 1980s, a lot of change occurred that the economic reforms started. So these reforms very suddenly. So the private sector, as a part of the globalization and privatization, private sector grown well. Today, it reached a peak level. The private sector globalization effects reached the peak level. So this we should first we have to assess this scenario. I think without assessing this scenario, we cannot talk much about the public health in India. So in this scenario, we are living. One thing. And second thing is now the medical student after entering into this, before entering into the medical school, also we have to assess. So what is the problem before entering a medical student or a paramedical student entering into a medical school? So how he is studying, we have to observe. So where he is studying. So if you observe keenly from the starting from the UKG, the student starting from UKG until ending with the long-term coaching or short-term coaching. So he is getting training under private sector, and their parents, his or her parents, putting a lot of investment from UKG to long-term teachment, long-term coaching, long-term coaching after intermediate. So with a lot of investment, what idea the student will develop? So what idea the parents will get? Lot of investment we made it, lot of profit we should get it from it. That's the main idea. So with this background, the medical students, now they are entering into the medical colleges. So now the question arises, how the medical ethics, how can you implement the medical ethics in this scenario? The medical ethics in this scenario became a myth. So the medical ethics we cannot implement because this became a just investment and profit like that. The education became investment and profit. That is the main pitfall we have to observe. And second thing is government, the existing government system, it's having its own pitfalls are there, and private medical system is having its own pitfalls are there. If you come to the government medical system, so a lot of, as already Srikanth Reddy garu explained, so lack of facilities, lack of infrastructure, lack of staff, both medical and paramedical staff, and also a lot of interference also. Suppose a disciplined HOD taking action over the people who are indisciplined. So immediate the political interference is coming in India. So that is also a big question to take control over the facilities providing in the government health sector. So we have to assess all these problems which are existing in the government healthcare system. And second issue, the private healthcare system is completely privatized and it's a typical business. So we need not much comment about it. A lot of exploitation were observed in COVID and non-COVID also, before COVID also, everybody knows. But when we allowed them, so when they have right, so it will go on. It's a typical business pattern only. We cannot comment. But totally, it's just as a vicious cycle of now the investment, profit, and became a business. So there is no trust over the doctors. and paramedical staff for the patients and the public. There is no trust. That's why a lot of agitations, strikes, and everything is happening in the country. Because due to the privatization, complete privatization, lack of control over the government sector, all these issues gone like this. And without touching the root causes, we are treating all illnesses in the public health. We have to touch the root causes in the ill events of the public health. And already Srikanth Reddy garu uttered that is the public health care. So importance of the public health. So very less when compared to the other countries. So we country often we are concentrating over the tertiary health care. So we are giving more importance to tertiary health care rather than giving to the primary health and public health. So that is also very important. We have to give more focus because today we are facing the COVID-19 pandemic. I don't think it stopped with the COVID-19. We may get some other viruses also. We may get other problem also. You see, so we are now the people are fearing for the mucormycosis, not for COVID. People are struggling because, okay, I will get the COVID, no problem. But if I get the mucormycosis, I may not survive. That is the opinion of the people. So a lot of fear existing, lot of apprehensions are there in the public. We are unable to address all these things. And ultimately, all this together, this existing system, this what we can say is a privatization and globalization, ultimately giving the profits to the multinational pharmaceutical companies and other companies which are producing devices, other equipment, medical equipment, are mainly drug industry. So these are all ultimately we are making the pharmaceutical companies rich and rich. That's all. So not only here, India, throughout the world also, because they are dictating now. There are times they are dictating, pharmaceutical companies dictating the terms. So we have to put full stop for this one. And finally, already I told that is we nowadays in the world there is all systems are democratic system are existing and other systems also existing. And at present, I don't think there is any socialism or communism existing in the world, including China and Russia. Typical, what we can say, it is not a communism, it is not a socialism. We cannot say. So we don't want any isms. We don't want any isms. We want actually public health. We want public health. We have to care to the people. We have to give the care to the people. That is our aim and objective. So in this scenario, we have to observe remaining countries in the world. We need not see only the USA or some other countries. We have to see other countries. We have to observe what are the public health programs are going on England. So what are the public health programs going on in the Canada? We have to observe those systems also. We need not follow any communist countries or any socialistic countries. So you see other democratic countries, how they are following the public health, how nicely they are controlling the maintaining the public health. This all we have to take into the consideration. So the intellectuals and doctors, they have to see the good country, the countries which are controlling public health, we have to focus on those countries also. So by that you can get a good idea how which you have to take, which line you have to take. We can conclude. And to get this one, and finally my urge is, so with the privatization, total education, not even medical education, total education. So total education and total health should come under government control. If they take this government total, these two departments comes under government control only, we can achieve all the targets in India. So we cannot compare our India to the other countries. So each country have different systems are there. We cannot convert immediately all those things. But we have to, as Srikanth Reddy garu told, we have to update. So especially Srikanth Reddy garu focused on the teleconsultation, telemedicine. So even it's not traditional for us, but we have to update regarding the telemedicine and teleconsultation. So with this, I think I am very thankful for this NSS coordinator Vivekananda coordinating this program. I wish you all the best. Once again, I am very thankful, sir, Srikanth Reddy garu, and we are very thankful to your nice lecture you have given for your NSS volunteers and faculty and doctors. So we'll follow your terms, sir. Whatever advices you have given, we will follow, and we will meet some other dias, sir, in a good time. We will give the good time to you. Elaborate. You can elaborate your views also in future, sir. We are always in touch with university, in touch with you, sir.
Thank you very much,
Thank you,
sir.
sir.
It's always a pleasure. Though on this particular occasion, I decided to give a broader dimension. But if you
Yes,
want
sir.
any discussion on universal health coverage in particular or non-communicable diseases in particular, that can be a very separate session, because it's the doctors I thought I'd address both undergraduate and postgraduate doctors about the kind of objectives of medical education, skills and values of medical education in a very general way. But on specific issues like NCDs, in which I have a particular area of interest, and also universal health coverage, which has been an area of passion, we can have a separate discussion. And I would like to have a lot more Q&A with the students, because that is where actually we can get a lot of ideas generated and issues clarified, rather than being a monologue by me. So maybe that session can be structured differently on a different date.
Yeah. Thank you once again.
Thank you, sir.
Okay.
Thank you, sir. Now, I request Dr. Vivekanand Kattimani garu to conclude the program with vote of thanks.
Thank you, Meghna, very much. So at the outset, we are going to conclude the program with permission from President of the program, Honorable Vice-Chancellor garu. So I thank university authorities, both Honorable Vice-Chancellor and Honorable Registrar, sir, for taking this initiation to acknowledge all healthcare personalities who has served in this pandemic for the healthy society on the occasion of Doctor's Day. Thank you very much, sir, for organizing this program. I am very much thankful to our chief guest speaker. Despite of his busy schedule, Dr. Srikanth Reddy garu accepted invitation, and it is within a short duration of notice. So hardly 3 days back, sir has consented us, and even we have contacted sir 3 days back, and readily he accepted our invitation, and he has enlightened very well about the public health situation in a very short and sweet way, so that all our budding doctors will take home message on the Doctor's Day. Thank you very much, sir, for your insights, sir. I thank all the faculty members across India and Andhra Pradesh who have joined for this program, and I could able to see many of the colleges have arranged the classrooms for listening to Srikanth Reddy garu, because this is an occasion where everybody has to be enlightened and everybody has to be acknowledged, even healthcare professionals and personalities apart from doctors, because sir has very well said it's a teamwork and team has to do well. Thank you very much for all the faculty who have joined with us. Once again, I thank you very much on behalf of Dr.NTR Health University for making this occasion grand success. Thank you, and wishing you all once again happy Doctor's Day. Now we are leaving the meeting. Thank you very much.